And our next section will engage race and medicine. So again, following all of the other sections that have occurred, I'll introduce the speakers and then the speakers will give approximately 20-minute presentations on their top topics. I'm sorry. All right, so our first speaker is Kamisha Russell. Dr. Kamisha Russell is an assistant professor of philosophy at the University of Oregon. She earned her PhD in philosophy from Penn State University. Professor Russell specializes in bioethics, critical philosophy of race, and feminist philosophy. Professor Russell is also co-editor of the highly influential Hypatia, a journal of feminist philosophy, and is the 2020-2021 recipient of the Baruch A. Brody Award and Lecture in Bioethics. Her first book, entitled The Assisted Reproduction of Race, considers the role of the race idea in practices surrounding assisted reproductive technologies and argues for the benefits of thinking of race itself as a technology. Professor Russell is also the co-author of an impressive number of articles, including Rights Holders or Refugees, Do Gay Men Need Reproductive Justice? Questions of Race and Bioethics, Deceit, Disregard, Disparity, and the Work of Decentering, and The Race Idea in Reproductive Technologies, Beyond Epistemic Scientism and Technological Mastery. Our second speaker on race and medicine is Yolanda Wilson. Dr. Yolanda Wilson is an associate professor in the Albert, I think that's Gnaegi, she can correct me, Center for Healthcare Ethics and affiliate faculty in the philosophy department at St. Louis University. She earned her PhD in philosophy from the University of North Carolina at Chapel Hill. Professor Wilson's research interests are bioethics, social and political philosophy, race theory, and feminist philosophy. Professor Wilson's publications include Intersectionality and Clinical Medicine, The Need for Conceptual Framework, Shrinking Poor White Lifespans and the Requirements of Justice, and How Might We Address the Factors that Contribute to the Scarcity of Philosophers Who Are Women and or of Color. Professor Wilson is currently working on a monograph entitled Black Death, Racial Justice, Priority Setting, and Care at the End of Life. All right, so please silently join me in welcoming Doctors Kamisha Russell and Yolanda Wilson.
Okay, so this paper or this presentation is titled What Makes an Anti-Racist Feminist Bioethics? It's a part of a longer chapter for an edited volume. And yeah, so there's only a little bit that I can get to today, but hopefully it'll be interesting for people. Okay, so what makes a feminist bioethics anti-racist? When we think about what makes an approach to bioethics feminist, we might look for 4 different but interrelated elements. 1, that it concerns itself with patients or subjects who identify as women, as transmasculine, or as gender non-binary. 2, that it concerns itself with sexism, gender discrimination, and androcentrism in biomedicine. 3, that it concerns itself with the way that categories like sex and gender are understood, taken up, or reinforced by and within biomedical practices. And or 4, that it explicitly employs explicitly feminist theories, frameworks, or methods in its analysis. Analogously, we might argue that in order to be anti-racist, an approach within feminist bioethics must contain 1 or more different but interrelated elements. 1, that it concerns itself with patients or subjects who identify both as women, as transmasculine, or as gender non-binary, and as non-white. 2, that it concerns itself both with sexism, gender discrimination, and androcentrism in biomedicine, and with the intersections with racism, racial discrimination, or white ethnocentrism therein. 3, that it concerns itself both with the way that categories like sex and gender are understood, taken up, or reinforced by and within biomedical practices, and with the way those categories themselves are always already racialized. And or 4, that it explicitly employs feminist theories, frameworks, or methods in its analysis that are themselves explicitly intersectional and or anti-racist. While not all feminist bioethics is anti-racist, all feminist bioethics could and should be anti-racist. While anti-racism is never easily achieved within academic, institutional, and broadly social contexts that are deeply racist, there is no gendered subject of feminist bioethical inquiry that is not also racialized, even or perhaps especially when that subject is racialized as white. Thus, all feminist bioethics is theoretically capable of addressing this pervasive racialization in its research and theorizing. Similarly, all discussion of race in bioethics could be feminist. And of course, all bioethical work, full stop, could be both feminist and anti-racist, but let's not try to gallop straight out of the gate. So here's a quick outline for the talk. I'll talk about how bioethics should understand race, what intersectionality is and why it's important here. I will mention some key bioethical issues for women and gender non-binary people of color, but I'll only be able to talk about one. Then I'll talk about reproductive justice as an example of coalitional bioethical work. And then, well, there won't be questions. There'll be Yolanda's wonderful talk, and then there'll be questions. Okay, so how should bioethicists think about race? It's worth making this explicit at the outset. Scientists have sometimes been called upon to pass judgment in ethical or political debates about race by proving or disproving the scientific, biological, or genetic basis of the concept. However, I argue that bioethicists should not place their focus on the falsity or truth of the race concept. It is certainly fair to say that the current scientific consensus completely discredits the idea that racialized differences in phenotype correspond either with significant differences in terms of the human genome or with significant differences in intelligence, physical ability, or moral character. In other words, the scientific consensus is that race, as we know it, doesn't exist biologically. It is also fair to say, however, that many people, including some scientists, continue to act as if race possesses the sort of reality that can be discovered or observed in nature. Thus, I argue that bioethical engagement with the concept of race must include a recognition and a reckoning with the social resilience of the race concept. Race is better understood, of course, following Chike from yesterday, as socially constructed, and as having the same sort of reality as other socially constructed things, like money. The value artificially assigned to precious metals, physical currency, and electronic records of capital and debt cannot be easily changed by any individual at will. So too, the meaning and value associated with certain physical characteristics and other markers of racial identity within a society remain largely beyond the control of individual identity holders. That is, I cannot declare myself white within my society any more than I can declare myself a billionaire, though under the right conditions, I might try to pass for either one. It is these identities largely beyond our control that determine our susceptibility or relative immunity to racism, which Ruth Gilmore aptly defines as the state-sanctioned or extra-legal production and exploitation of group-differentiated vulnerability to premature death. This is the second crucial requirement for bioethical engagement with the race concept. One must understand that a racialized embodiment leaves certain people vulnerable to the direct or indirect health effects of racial discrimination. Direct effects include negative health effects of chronic stress caused by consistent experiences of discrimination and inferior treatment by healthcare providers due to racial stereotypes. Indirect effects include the negative health impacts linked to low socioeconomic status, itself linked to minority status, like increased exposure to pollution and toxins, reduced access to healthy food, and chronic stress related to worry about money or exposure to violence, including state violence. In other words, rather than worrying about what race is biologically, bioethicists must worry about what race does to the body. Much of Michel Foucault's work involves uncovering and delineating what he calls regimes of truth, which means not declaring any particular regime false or misguided, but rather exposing both the ideas and assumptions that characterize a particular regime of truth and the concrete means, instruments, rules, and practices through which that regime of truth emerges, is instantiated, and is maintained. In this vein, to engage in anti-racist work, bioethicists must understand race, as I've described it elsewhere, as a sort of non-existent yet very much real object, established and continually reestablished through a set of practices emerging from and upholding particular regimes of truth and serving particular political functions that are nevertheless disguised by the way in which rules and practices surrounding race act as if it exists. This means both recognizing the negative health effects of racism and becoming aware of the way that white ethnocentrism has shaped and continues to shape both biomedicine and bioethics itself. For feminist bioethics, anti-racist work can begin with the recognition both of the importance of intersectionality or similar theoretical concepts to anti-racist feminist theory, and of the importance of the perspective of women of color on any feminist bioethical issue. While the definition of intersectionality is frequently and often productively contested, we might establish a working understanding of the theory by elaborating its key insights, motivations, and demands. As Kimberly Crenshaw's seminal metaphor establishes, intersectionality recognizes that it is possible to be situated at the intersection of two or more marginalized identities, and that when one is so situated, it will not be possible to disentangle the two or more forms of discrimination that acted to produce an experience of injustice. Thus, for example, when considering the disproportionate incidence of low birth weight infants born to Black women in the US, which seems to be attributable to chronic stress over the life course, it will not be possible to separate out the percentage of stress that comes from being Black from that comes from being a woman. Moreover, intersectionality as a theory rejects an additive approach to oppression. That is, the chronic stress that accompanies being a Black woman in the US is not the stress of being Black plus the stress of being a woman. The stress of being a Black woman instead emerges from the particular structural locations Black women occupy and from the particular stereotypes or controlling images through which much of America perceives and responds to Black women. For example, a pregnant Black woman seeking healthcare does not simply encounter two sets of stereotypes, one that as Black she will be irrational and non-compliant, and another that as a woman she does not know what is best for herself and will overreport her pain level. She also encounters stereotypes specific to Black women, that she is gaming the system to receive care she hasn't paid for and does not deserve, or that the life of her child is already less valuable than that of other children, since the child will probably grow up poor and without a father, and since the mother probably has too many children already. Further still, intersectionality resists assumptions that any two people who appear to lie at the same intersection of identities will share the same essential experiences. Not only are identity categories numerous, e.g. not just race and gender, but also class, sexuality, disability, age, color, ethnicity, etc., but they combine with families, geographies, temperaments, and individual experiences. Moreover, what is at issue is the operation of power in and through these various identities. These operations are multiplicitous and shifting and do not act on any two individuals in the exact same way. These key insights emerge from and structure the motivations of those who take or work from intersectional approaches. There is, for many, a desire to make legible experiences of marginalization and injustice that are often rendered illegible by the very analytical tools one would expect to illuminate them. Thus the arresting title, "All the Women Are White, All the Blacks Are Men, but Some of Us Are Brave." When white women are seen as the leaders and beneficiaries of feminism, and Black men are seen as the leaders and beneficiaries of anti-racist struggle, Black women are not simply left to become passive beneficiaries, but often find their particular needs and concerns theoretically obscured and materially unaddressed. The desire to make legible is thus not simply an academic point, but rather one that emerges from and continues in the service of advocacy and activism. As a theory, intersectionality does not just observe and critique, it intervenes and seeks to transform. And it demands. Non-intersectional approaches to issues of social justice are not just incomplete, they are dangerous. While not additive, different structures of power and oppression are co-constitutive and mutually supportive. If they are not acknowledged and addressed together, there's a great risk of worsening injustices at one location while attempting to alleviate them at another. This makes intersectionality crucial for any project seeking to address inequalities and injustices, but it is particularly crucial for bioethics because bioethical issues are embodied issues, and so many forms of discrimination rely on social perceptions of one's embodiment and the meanings that embodiment is thought to entail. In white colonial and settler colonial states, no researcher, no subject, nor doctor, nor patient appears in any biomedical context without a gendered and racialized set of experiences and embodiment, to say nothing of the many other bodily markers that are taken to signal other forms of difference. Moreover, research on issues like chronic stress, epigenetics, and intergenerational trauma demonstrate how perceptions of one's inferior embodiment can actually compromise one's embodied health and well-being. And in fact, medical interventions often seek or serve to alter one's embodiment, sometimes with the aim of restoration to an earlier state of one's own health, but other times with the goal of bringing one's embodiment into greater conformity with norms modeled on the ideal of a white, able-bodied, neurotypical, heterosexual, cisgendered man. While feminist bioethics is constitutively concerned with the embodiment and biomedical concerns of women and ideally gender non-binary individuals, without due attention to and solicitation of perspectives from a variety of women and non-binary people of color, it will always be at risk of 1, missing important problems, 2, failing to identify the most promising solutions, 3, failing to meet the needs of those in greatest need, and 4, reinforcing the very structures it seeks to critique and transform. So in the longer version of this work, I discuss a variety of key bioethical issues for women and non-binary people of color. For example, historical patterns of reproductive experimentation and abuse, contemporary racial disparities in health access and outcomes, issues related to incarceration, issues facing trans and gender non-binary people of color, etc. But today, there's a few others. Today, with limited time, I'm just going to give the example of environmental injustice. So though the definitions of environmental injustice and environmental racism are contested in terms of what exactly they name and encompass, for our purposes here, I interpret them broadly. Thus, following Breonna Taylor, we might take the term environmental racism to describe processes resulting in, quote, minority and low-income communities facing disproportionate environmental harms and limited environmental benefits. Under this umbrella, we might then consider at least 4 broad and overlapping ways in which people of color find themselves living in environments that are hazardous to their health. First, and perhaps most traditionally for the idea of environmental racism, there's the likelihood that poor people and people of color will find their communities targeted for the placement of waste disposal and other environmentally hazardous sites or polluting industries. Teresa Benz, for example, identifies some of the numerous studies that have found race to be the strongest predictor of exposure and proximity to environmental hazards. She also notes considerable evidence of direct links between racial segregation, exposure to environmental hazards, and poor health outcomes. Kyle White gives the example of the Amjiwinang First Nation of 850 members that is situated within 25 kilometers of 62 major industrial facilities, from oil refineries to manufacturing, in a region often called Chemical Valley, which is by Sarnia, Ontario. Second, marginalized communities, and in particular Indigenous communities, have often been forced off their traditional lands, relocated to lands with fewer resources, and then relocated again if previously unrecognized resources are discovered on the lands they were forced to occupy. This leaves such communities impoverished, sometimes with limited water access, and often with substantially reduced means of subsistence to sustain healthy traditional diets. Yet the existential damage of these dislocations, as my earlier mention of mental health and substance abuse, which is actually earlier in a longer version of the paper, runs much deeper. As White describes, settler colonialism can be interpreted as a form of environmental injustice that wrongfully interferes with and erases the socio-ecological context required for indigenous populations to experience the world as a place infused with responsibilities to humans, non-humans, and ecosystems. Third, similarly, but in the urban rather than rural context, marginalized communities, and in particular Black communities, have often been funneled into urban housing projects, which, aside from often being located in areas of less economic value and or adjacent to industry or major transportation corridors, have often been characterized by poor construction, poor building code enforcement, and poor maintenance. These unsafe housing environments increase exposure to environmental toxicants and home allergens, which contribute to health issues like asthma or lead poisoning, especially in children. Finally, in both the urban and rural contexts, marginalized communities may, by a combination of market forces and government neglect, both fueled by underlying racism, lack proximate access to a number of goods and resources required for the maintenance of health or a healthy lifestyle. Among these lacking goods and resources may be large supermarkets with low prices. Convenience liquor and small grocery stores tend to offer a more limited selection of healthful foods at higher prices. The lack of pharmacies and safe outdoor spaces for recreation and exercise. As Lee et al. Note, people tend to make dietary choices based on the quality of food that is available and economical. And even if one's individual socioeconomic status is higher than one's neighbors, simply living in a deprived neighborhood is associated with eating fewer fruits and vegetables and more foods high in fat. Environmental racism and environmental injustice work are of particular interest here for the way they interconnect with the broad-based coalitionary demands and goals of the reproductive justice movement, which, as I argue next, is exemplary of anti-racist feminist bioethical work. So here I wish to emphasize the features of the reproductive justice movement that I feel should be adopted in the practice of anti-racist feminist bioethics. The reproductive justice movement is coalitional and has been led by women of color. The reproductive justice framework uses the experiences of women of color to oppose any ethical discourses on reproduction that focus primarily or exclusively on a white middle-class woman's privacy right to make a choice about whether or not to have an abortion. A narrowly individual right to choose is inadequate to addressing the histories and present-day cases of racialized reproductive inequalities. Taking these histories as crucial to the movement, the reproductive justice framework insists not only on a human right not to have children, but also on both the right to have children and the right to parent the children one has in safe and healthy environments. It also sees these rights as entailing the obligation of government and society to ensure that the conditions are suitable for implementing one's reproductive decisions, requiring at a minimum that all reproductive choices be safe, affordable, and accessible to women. I think it is clear in this example that centering the issues of women of color does not mean ignoring the individual rights of white women, but aims in fact at improving reproductive conditions for all women. The ethical or bioethical, where it is centered on autonomy, conceived in terms of personal freedom, and especially in clinical contexts, tends to focus only on what is or is not permissible in biomedical practice in terms of individually conceived ethical rights, duties, obligations, and prohibitions. With ethical rules in place, much of patient and physician decision-making is taken to be a private matter with little relevance to politics or social justice. By contrast, an anti-racist feminist bioethics must explicitly concern itself with the political, that is, social responsibility, collective life, the power dynamics and inequalities of social orders, and the role that concepts like race have played in creating and maintaining such inequalities. To create an anti-racist feminist bioethics, we must insist upon not only the necessity, but the centrality of discussions of race to the broader field. We must show that there are vital lessons to be drawn from the experiences of racial minorities for bioethics as a whole. It is not simply a matter of applying bioethical analysis to the problems of marginalized people to help them out or be more fair. Rather, it is a matter of making bioethics more genuinely universal in its scope by gathering more perspectives, not merely as a collection of incommensurable experiences, but as a means of obtaining a more comprehensive and more just view of the world. It is a matter of recognizing real deficiencies in current bioethical knowledge and correcting those deficiencies in order to develop better practices for everybody, including even those privileged persons whose lives most closely approximate the rational, autonomous individual at which much of bioethics has thus far been aimed. My last couple of sentences. We must go beyond simply adding some attention to the problems lying at the margins of bioethics, we must look from the margins of bioethics towards the center in order to critique and ultimately to displace that center in favor of something more expansive, more responsible, more responsive, and much more flexible. Thank you.
All right, thank you for that. And now our next speaker will be Dr. Yolanda Wilson.
I'm glad to be here, and I'm actually glad to be in a session with Kamisha. So this is going to be really exciting for me. I find that this piece that I'm presenting is partly in progress, but it's also not just in progress, the way often our work is, but I'm really kind of shifting and rethinking how I've responded to questions about trust in healthcare among Black people. And I have a chapter on trust in the monograph. And so recent events have really have me kind of rethinking and shifting even how I think about trust in the monograph, although there'll be some conversation of COVID, because who does bioethics in 2021 and without mentioning that, and especially in the context of this particular paper. So any feedback will be really helpful. Lately, I find that I'm asked a lot, right? Why Black people don't trust medicine, or specifically vaccines, or more specifically, the vaccines that have been created to combat SARS-CoV-2. And so I'm asked these questions. So kind of the audience I have in mind, or how I'm thinking about being asked these questions is as part of public discourse. So, being interviewed or writing public articles. And so this is how I'm thinking about framing this particular piece. So although the interlocutor is often asking the question innocently as one can ask such a question, given the baggage of the history of racism and power, I find the question at best strange and at worst insulting. Now, I have to confess, I didn't always find the question strange or insulting, and I think that some of that, I didn't always find the question as insulting as I find it now. Not that I didn't always, or as strange as I find it now, but I think my ears have tuned differently in recent months. So in the few moments that we have together, I want to explore preliminarily the heavy lifting that the word trust is doing in this question, and what, if anything, comes from it. Implicit in the why don't Black people trust medicine, healthcare, physicians, nurses, etc., is the idea that if only Black people were more trusting of healthcare institutions and the people who operate within them, then many of our, Black people's, health-related problems would go away. So I'll give you a brief roadmap. In thinking through this question, I want to begin with what's wrong with the question itself. I should say at the outset that what I have in mind is the public discourse around Black people's trust and distrust, trust or distrust. Implicit in the question is the pathologizing of Black people. I argue that there's something wrong with Black people, rather than there's something wrong within the conditions within Black people operate. This sense that there's something wrong with Black people serves to further disadvantage Black people, and also ignores the role that healthcare institutions have played and continue to play in fostering a climate of mistrust. I then show that even attempts to explain the mistrust fail to adequately capture the harms committed against Black people, even as they gesture at some forms of institutional or structural responsibility. Finally, I will briefly sketch out what is important about trust, but why it may not be the answer to the problems that Black people face in healthcare encounters. I do not mean to suggest that trust isn't important for Black people in healthcare contexts. However, I am interested in thinking through precisely what is important about trust in these contexts. So to turn to pathologizing Black people, and I don't think I'm saying anything particularly radical here. Maybe in this context, it's not the assumption that a lot of bioethicists kind of come to the table with. But to lay my cards on the table, there's something about questions of the form, why don't Black people do X, or why do Black people X, that raises a red flag for me. And that's just me. That's, apart from thinking about this in a bioethics framework, but just in general, anytime I hear kind of why do Black people do X, or why don't Black people do X, and it's often asked by someone who's not Black, we can talk about this, right? So due to time limitations, I won't spend time discussing Peirce or Grice or conversational implicature and what happens off stage with regard to linguistic acts. However, I think it's fairly well-worn philosophical territory to say that speech acts do not occur in a vacuum. Rather, they occur within specific historical and cultural contexts. In order for conversation to happen successfully, both utterers and hearers are aware on some level of these contexts. even if no one explicitly describes, introduces, or appeals to these contexts in a given exchange. So while the question may seem innocent enough to the interlocutor to ask, why don't Black people trust whomever, right? Nurses, doctors, physicians, healthcare institutions, social workers, whatever. When asked in the context with a lot of racist history and racist present, it's happening off stage. And the offstageness involves figuring out what is wrong with Black people. So, a question that may be a sincere attempt to understand whatever specific thing the interlocutor feels needs to be understood, it carries with it, intentionally or not, racist stereotypes about Black people's general intelligence, capacity to reason, and ability or willingness to make the best decisions by which to govern Black lives. In other words, the question is a normative one, not a descriptive one. Contained in the question is often the belief that Black people should be doing something differently, should be making different life choices. At best, it's the implication that there is something inherently wrong with Black people's decision making. At worst, is the implication that there's something wrong with Black people as Black people. So, I think to just explain this a little bit more, right? The question of why don't Black people trust, or, just broadly, why don't Black people do X? Um, I think although the questioner may consciously be asking an innocent question, although, to follow James Baldwin talks about how a certain form of innocence is a problem in and of itself. I think that we can't ignore these kind of broader cultural contexts in which Black people are often regarded as just inherently deficient, defective, either as Black people or in our capacity to reason and make decisions about our lives, right? So the question itself, I think, reflects a moral failure to fully humanize Black people. However, it also fails by situating trust, mistrust, distrust at the feet of individual Black people, or of Black people as a collective, or of Black communities, rather than assigning any responsibility or blame on the sociocultural contexts within which Black people operate. And we can talk about this more during the Q&A, of course. So, one strategy deployed in an attempt to reject the pathologizing of Black people is to concede the premise of the question, right? That Black people are distrustful, and offer explanations for this distrust, usually with appeals to historical or continuing racial injustice. The form of the response tends to be, it is correct that Black people don't trust, take your pick, medicine, physicians, nurses, healthcare institutions, etc., right? Fill in the blank. But there are good reasons for this. And then the respondent will proceed to argue by example until they feel the case has been sufficiently made to defend Black people's honor or intelligence or what have you. I've adopted this line myself, and I don't think it's a bad line of thinking, right? I don't think it's terrible. I'm not here to kind of reject that. And certainly, I've said it in print a couple times, either in my own stuff or in interviews for other people. I'm also clear that this line of thinking is an attempt to push back against assumptions that Black people are simply too stupid to make reasonable decisions about health, and that it may in fact be rational for Black people to be skeptical about just treatment in healthcare context, right? So this kind of line of thinking of, well, yeah, there's this distrust, but, and then you point to whatever forms of examples that you think ground that distrust. It's definitely a kind of pushing back against the implicit assumption that Black people are just not bright or irrational or superstitious, or I've also heard in these in bioethics kind of spaces, too overtly religious and Jesus-y to kind of make, to appreciate science. So any form of that, right? So to paint a picture a bit, arguments by example defending Black distrust of healthcare often appeal to one or more of the following historical practices: the Tuskegee syphilis experiment, the practice of robbing graves of enslaved people for use as cadavers, J. Marion Sims's gynecological experiments on enslaved Black women, while inviting audiences to gawk at their vaginas, by the way. Forced sterilization of Black women in the South, the taking of Henrietta Lacks' cervical cells without her consent, and the subsequent development of the HeLa cell line. It's made a lot of people a lot of money, and the experimental treatments performed by university medical centers, right? So you'll see one or all of these. These appeals to history are attempts to show all the reasons that Black people have to be skeptical. Again, I've done this myself in print. Another explanatory strategy is to appeal to current practices, right? So not to talk about the history. Although, as I like to tell my students, even these things that we think of as historic didn't happen that long ago, right? The last survivor of the Tuskegee experiment, for example, just died in, I think, 2004. So not that long ago. Again, conceding Black people's distrust, but grounding it in recent examples. So racial maternal fetal mortality disparities, racial pain management disparities, racial disparities in use of restraints in hospitals, particularly for mental health patients, but also for other patients. And most recently, racial disparities in COVID testing and hospital admissions for positive COVID cases. Right? I've pointed to these examples too. So again, I'm not rejecting the idea of this kind of explanatory strategy. However, while piling on example after example of these kind of racist practices or instances may show that a certain amount of distrust is rational and in fact prudent, I find myself growing more and more dissatisfied with this explanatory strategy. In fact, as more ink is spilled over the search for answers to the problem of Black people's SARS-CoV-2 vaccine hesitancy, I've begun to find the explanatory strategy, both historic and kind of current, lazy for at least two reasons. First, while the explanatory strategy is often accompanied by an appeal for corrective measures by institutions, for example, community advisory boards or concerted outreach efforts to so-called underserved communities, the fundamentally unjust conditions operating in the background go unaddressed. Second, trust seems to do a lot of heavy lifting in the question, why don't Black people trust medicine, healthcare, physicians, nurses, vaccines, et cetera? Science. I heard science. A journalist actually reached out to me and with the and asking the email, Professor Wilson, I know your bioethicist, I'd like to talk to you about, I'd like I'm writing this article on why Black people don't trust science, and I'd, like you to weigh in on that. All right, so science generally. Um, and as I see more uptake of the explanatory position, right, this explanatory strategy, I find myself more and more puzzled by the work that trust is supposed to do. So in what remains, I think 7 minutes, I want to think about possibilities for trust and whether broad adoption of this explanatory strategy has unintended consequences, namely an over-reliance on fostering trust. So trust is a general principle and why it matters. In questioning whether trust is enough, I'm acknowledging that trust can and does serve an important function. In general, trust fosters social cooperation, while the absence of trust inhibits it. One need look no further to prisoner's dilemma or stag hunt type thought experiments to see the function of trust in these scenarios. While often couched as showing conflicts of public versus private reason, the elements of being able to trust one's compatriots to act according to what is best for the whole underlies the tension of the thought experiment. In these cases, defection can be understood as at least sometimes being motivated in part by not being able to trust others to uphold their end of the deal. Repeated instances of not upholding one's end can lead to a breakdown in even a willingness to cooperate. Our social lives depend, to the extent that trust is present, on being able to believe that others will show up and fulfill their obligations to us and that we will do the same for others. Otherwise, friendships, romantic relationships, professional alliances, and even institutional practices don't get off the ground. So, in that sense, trust is instrumental. However, trust may also have intrinsic value. Perhaps there's something significant about being the sort of being who is secure in knowing that others will consistently show up for them, honor commitments, and have their well-being in mind. So in healthcare environments, there are good data on the value of trust. For example, patients who trust their clinicians report fewer symptoms and greater satisfaction with their clinical encounters than patients who don't trust their clinicians. Additionally, health systems that are committed to fostering trust between the institution and the community, particularly the surrounding community, right? You see a lot of this work around, particularly university medical centers that sit within so-called underserved communities, right? So health systems that are committed to fostering trust between the institution and the community are able to work more collaboratively toward advancing health. And in specific studies of clinician race, it turns out that racial concordance between patient and clinician, in other words, patients and clinician being of the same race, fosters greater trust within the patient. And we can think about why during the Q&A. And perhaps this heightened trust is for good reason, particularly in the case of Black patients, beyond simply feeling better about the encounter. As it turns out, for example, Black babies are less likely to die in hospital when cared for by Black clinicians. Certainly on the matter of trust in Black patients and clinicians, there seems to be a feedback loop happening that's beyond the scope of this specific discussion, but is interesting nonetheless. Patients are more likely to follow through with treatment plans and are more likely to feel positively about their encounters when they trust their clinicians. So clearly, trust is doing some good, important work here. At the same time, I worry that relying on trust as explanatory may overshadow the structural injustice that operates in the background and often in the foreground of healthcare contexts. It is important to foster and develop trusting relationships with the patients and communities that healthcare environments serve. Part of fostering trust is for these institutions to show themselves to be trustworthy. It is worth thinking about what steps should be taken in order to achieve this. Yet, even if healthcare institutions are committed to fostering trust and showing trustworthiness, doing so does not happen, for Black people at least, within a reasonably just society. I appeal to Rawlsian language here because I think that the dominant sensibility of the US is that the US is a reasonably just society and that it just needs a little tweaking. And if that's one starting framework, then what's required is going to be different than if one rejects this assumption. So then, what would trust even look like in a society that is not reasonably just, particularly as it relates to Black life? And if one could imagine the look of trust under these conditions, then what work would trust be equipped to do? At best, reliance on trust under conditions of unreasonable injustice could only facilitate incremental change. For example, a few more Black people may get vaccinated than otherwise. However, the number would not be and could not be dramatic. Why not? Well, because conditions of greater trust would likely capture those who have access to the kinds of goods and resources necessary to facilitate certain kinds of health seeking behaviors, and who would do so but for distrust. Absent concerted efforts to bring about a reasonably just society, efforts at building trust would not change the condition of many who are most profoundly affected by injustice, but it might let responsible parties off the hook by allowing them to fall back on the laziness of trust, right? We tried our best, but Black people just don't trust us, right? One quick thing I want to flag. I'm not suggesting that no Black people feel profound and justifiable distrust toward healthcare environments or toward COVID vaccines specifically. It is the case that for some, Tuskegee forms part of the cultural milieu. I'm actually related to a lot of people who have that position. Look what they did to us with Tuskegee, right? It's a legitimate stance that people take. It also might be the case that when one's options are unjustly constrained, relying on cultural narratives of distrust may also be a way to ease the pain of certain forms of exclusion. In other words, one can simultaneously have justified misgivings about a proposed health intervention and experience frustration at being thwarted in one's attempts to secure said intervention. Multiple things can be true simultaneously, and it would behoove those of us who care about Black people and Black health to understand the nuance. Why don't Black people trust doctors, nurses, healthcare, vaccines, hospitals, science? Isn't a sufficient question to ask, and much of the time it's the absolute wrong question to ask. I see tremendous value in upholding the humanity of a people whose justifiable reluctance to engage in healthcare environments has been routinely dismissed as stupid, irrational, and childlike. At the same time, I worry that embracing an explanatory narrative might lend itself to overvaluing the role of trust. While trust has to be part of the discussion, it can't become the discussion. Thank you.
All right, so let's silently give our speakers, Doctors Russell and Wilson, a hand, and I would like now to open it up for questions.
One yet. I was curious to ask Dr. Russell if you if you saw any tension between your view and the need to study different effects of drugs on different groups, drugs that are being developed, and as well as experience of certain medical emergencies like heart attacks, for instance. And if so, what you have to say about that.
I mean, I'm not sure. I guess if you would like to sort of tell me what tension you're sort of thinking, I would not think of it as attention. I would think that actually, yes, attention to how different problems manifest in different groups, what and sort of would be better diagnostics. I mean, that's a matter for me of actually paying attention to non-white people and not taking that sort of white male as the sort of standard of a human body, right? So yeah, I mean, I would see that as part and parcel of the kind of stuff that I'm thinking about. But if you have a specific tension in mind, please go ahead.
I don't hold this view myself, but I was thinking that viewing these as social constructs rather than biological realities might lead someone to make that type of objection.
Okay, yeah, okay, I see what you're saying. Yeah, I mean, I don't think that we know. I don't think we know what physiological differences, other than gender sometimes, right, account for different experiences of symptoms and stuff like that, right? So I don't think we have to say that, and I don't think we should say that they're race-based. I think but we should sort of have a diverse enough population that we're studying to collect a sort of set of symptomology of various illnesses, that can apply to a wide variety of people. You just don't know kind of what, and I think that a lot of what may account for differences between white and non-white people, and particularly white and Black people, are the sorts of factors I mentioned in terms of like the sort of chronic stress, the sort of epigenetic effects of unhealthy environments or unsafe environments, precarious environments. So I think we can sort of imagine that there might be some physiological differences between broadly speaking, Black and white people that are based on, sort of environment, social experiences, chronic stress, discrimination, that kind of thing. So we can sort of look at some of these effects that racism might have physiologically. I mean, but it shouldn't go the sort of full way to just stereotyping. This is what a heart attack looks like in this person and this person and this. Like we shouldn't, but we should have a sort of wide range of things that we're looking for, and not necessarily associate particular diseases with only sort of one target group too, right? That's another source of race-based misdiagnosis. But yeah, I think we can sort of imagine that there's a variety of ways that people express symptoms, and imagine that might sometimes correlate with communities without saying that it has to have a sort of biological racial basis. It could be, the result of histories of racism. And, as I mentioned, there's epigenetics, there's transgenerational trauma. There's a lot of different things that can sort of happen over time that aren't biological race as it's been sort of described.
Do you, either Dr. Johnson or Dr. Russell, have a question for Dr. Wilson, or does Dr. Wilson have a question for Dr. Russell?
I'm curious when we sort of think about trust. This is because you mentioned one of the articles that was mentioned in your introduction talked about poor white people. I'm fascinated by poor white people. So Yolanda, I wonder if you have thought about trust with poor white people and medicine, right? I mean, so this sort of like this non-belief in COVID, for example, or the vaccine reluctance of certain groups of white people. And if you think it bears similarities with what you're sort of thinking about with trust in Black people.
Yeah, so actually I have, and interestingly enough, I feel like I say this every time I talk about COVID. My hometown was a significant hotspot, and around the time that New York was actually had a higher per capita infection and death rate than New York did. We were number 3 in the world, when New York was number 7. Although because we're a rural area, of course. wasn't the same attention. But what's interesting now, almost a year later, is that we're seeing a certain kind of vaccine hesitancy among some of the whites in the community, particularly, well, I wouldn't just say poor whites. I think sometimes rural white and poor white get cashed out as synonymous, and they're not necessarily. And people mean rural white sometime and just call all rural white people poor. But I think that sometimes the reasons for vaccine hesitancy get all jumbled together, and there's not a kind of nuance around what it is that poor white people are thinking and experiencing in terms that look very much like what other communities experience in terms of, for instance, access to healthcare or how one is treated in the healthcare encounter. But right, so there's similarities there, but I also think that there are significant differences, and some of the COVID isn't real talk relies on a certain framework of whiteness and a certain kind of investment in whiteness as a racial project that allows one to say, oh, it's mostly these other people who are dying, and they're probably not even dying of COVID. They're just being counted as COVID deaths. And then, you can choose your own kind of wacky conspiracy around that. The doctors get paid for calling deaths COVID deaths or whatever. But that we would do a disservice to ourselves as bioethicists, and I think a disservice to kind of health justice, to not take seriously the role that kind of whiteness and investment in whiteness plays in not just COVID denial, but other forms of health-seeking behavior that poor whites engage in or refuse to engage in. So I would ask you, this is so awesome, Kamisha. I'm so glad that we get to have this conversation together. I don't know if this is a question so much as just a kind of like a compliment that you can run with. I like how you're thinking about and this is a kind of inside baseball thing, I think, among how bioethicists often work. The importance of connecting environmental justice to reproductive justice, to kind of racial justice and intersectionality as not just being things that bioethicists should care about, but as being fundamental to the project of bioethics, right? As being fundamental to the core of why bioethics exists. And it's a little bit different than those principles that we're taught, right? Autonomy and justice, but it is, right? It seems like it's kind of pushing to what the discipline could be. And I just would love to hear more about just how you're thinking about that and how those things come together.
Yeah, thank you. And I think it does, it connects, I think, also with sort of your saying, hey, let's not focus all on trust, right? Because trust is also, it's part of that sort of it's like it's additional to the principles, but it's one of those sort of sub principles. There's 3 or 4 of those that, in that clinical encounter, right, where it's sort of you need the sort of trustworthy clinician and the patient who can trust their, that and that's sort of this space. And I think, you're pointing as well to oh, we have a much bigger space of injustice that we really need to think about, before we can sort of before trust, this individual trust would even sort of really come to do anything significant. We'd have to have a much smaller group of people who were having issues with the healthcare system before we could really focus on that. So yeah, I think I see them as really kind of similar moves. It's interesting. This chapter is for the Rutledge Handbook of Feminist Bioethics or something, and they're like, will you do the chapter on race? And yeah, sure, I'll do the chapter on race, but also what, what does it mean that you have a sort of handbook of feminist bioethics, and then in one chapter, and these Rutledge handbooks can be pretty big, that so that you're gonna just sort of have all the stuff, and then there's race. I don't know, what does that mean, right? Like, I mean, it really sort of says, like, here's this sort of like one thing. So, I mean, part of the goal then, you know, with the chapter, right, is to sort of insist on, you know, the centrality and the necessity of this. But I think that, I mean, it's just so common to be asked, or I'm sure it's common for you, to be asked in the bioethics field to write about race in some like location where like race is like sort of on some checklist of things that should be included in some kind of sort of comprehensive volume. So, and I feel like this is in part what you get for being one of a few, you know, sort of Black bioethicists. But yeah, I don't know. So I mean, yeah. So part of it was kind of trying to think about like how can we make this more central, and how can I sort of participate in the project while resisting something about the way in which I was invited to the project.
Good afternoon, everyone, and thank you both, Dr. Wilson and Dr. Russell, for your enlightening and very thoughtful presentations. I was here wrestling a little bit. I've been wrestling with this question a lot. I'm not a bioethicist by trade, but I've studied a little bit of it in undergrad. 2006, I graduated, then I graduated from seminary in 2012. And one question that I haven't, or one area that hasn't, well, has been brought up here recently is the body, particularly the Black body, and particularly within womanist thought. And can you talk more about that in regards to, and not womanist, but how the valuation of the Black body going all the way back to chattel slavery, and then the devaluing of the Black body in regards to police brutality and killings and the such, and how do you see that this area playing out in bioethics and in regards to the field, and opening up a conversation that wasn't there before in regards to normalization of whiteness in the white body? So thank you.
So, you know, I like that you mentioned chattel slavery. So I think that one place, you know, I talked about kind of grappling with history and giving contemporary examples and whatever impact that may have on trust. I think that one really clear example is the development of US medical schools, particularly the ones in the South. That there's a very clear history there. Harriet Washington talks about it in Medical Apartheid, and there are other people who talk about it. Very clear history between the connection between, you know, plantation owners and the development of these medical schools, and renting enslaved people for medical experimentation, and also the practice of grave robbing of enslaved people's burial sites to procure cadavers. I think many of us know, if you know anything about kind of the development of kind of medical schools and medical practice, that a lot of cadavers in the early days were procured by grave robbing. But specifically in the South, graves of enslaved people were targeted. Do I want to say that that looms large in the history or in the collective consciousness of Black communities? I've said something to that effect before. I think it's probably overstating it. But I will say that these kinds of practices, right, that if we're going to reckon with what bioethics looks like and what medical practice and nursing practice look like, you have to reckon with the reality of how these things came to be. I mean, I mentioned J. Marion Sims, and, you know, he's widely regarded as the father of modern gynecology, but he got, you know, he was able to do that by experimenting on enslaved Black women. And, you know, to think about particularly something like trust, university medical systems certainly have a long history of not necessarily experimenting without consent, although there's that, but also with consent, treating Black patients as research subjects first, and patients somewhere maybe even second, maybe not even second, maybe third or fourth down the line. And so when you think about the context in which we have medical discovery and continuing medical practice and patient treatment, we have to think about the space or the role and how these things came to be. And that's part of the reckoning for me.
Yeah, and I was sort of taking maybe a slightly different direction. I'd say that, you know, I mean, when we think about sort of the move from medical ethics to bioethics, and sort of trying to think about a more expansive bioethics that, you know, sort of concerned with the life of people on the planet, and also hopefully also concerned with the life of the planet. I mean, because again, it's sort of this this reproductive justice view, right? If you read books on reproductive justice, you'll find that there's a ton of different issues that all connect up with this idea of being able to have or not have children, and then to be able to raise them in safe and healthy environments. It connects to mass incarceration and the environment, and all kinds of different. It seems that there's at some point there becomes almost no issue that is not a sort of reproductive justice issue, right? And I think that can be helpful. And so I think when we think about bioethics in this terms of sort of this survival of human beings on the planet, right? Then I think we have to think about how racism pits the survival of white people, or Black people and white people against each other, right? How there's this view, this underlying view, I think, of white supremacy that Black bodies pose this existential threat to white bodies and to whiteness, right? And so, and I think about this obviously in terms of sort of police violence and stuff like that. If you really take seriously the kinds of things that officers who shoot unarmed Black people say, if you think that what they're describing is their real experience, right, then they have this idea of this sort of threatening Black body, right? And so I feel like if we want to really kind of think about a sort of version of bioethics that says what would allow human beings to live well and healthily on the planet and to survive, right? I think racism is then right at the center of that question, because as long as sort of some people are perceived as this threat, that's going to be a sort of justification for shooting or locking up or disregarding or reproductive abuses, right? Because that's also based on this idea that Black people shouldn't be reproducing as much. And I mean, so I don't know. I think for me, racism becomes really core to that. If you think about this idea that white supremacy sees the Black body as this existential threat to life. So that's sort of a more theoretical or abstract version, but that's what your question made me think of, Curtis.
I have, I guess, two questions. I see Grant's hand. We have about 5 minutes left. This is more just sort of an unformed thought to which you don't have to respond. But I have a question about, I read this article a while ago from Michelle, I think, Goodwin, about organ transplantation. I think this question would probably relate more to Dr. Wilson in terms of trust. And in the article, she gets into sort of why African Americans don't tend to be organ donors. And I guess there's a pragmatic question there, and I understand your hesitancy to speak about trust. But when we look at organ transplantation and things like that, might we of necessity have to try to cultivate a kind of trust, because the numbers that she gives in terms of organ shortages, now this is a fairly older article, it motivated me to become an organ donor when you look at some of those numbers. So like, it's an unformed question, but what might you say to that, Dr. Wilson? Then I have one, just a slight one for Dr. Russell. It seems like you want to abstain from the truth or falsity of race biologically. I think you said at the beginning of the presentation that you take race to be a sort of a social construct. What would you say to something like Bidil? That heart medication. There's a book. There's a really important, I think, book on sort of the politics of the creation of the drug. I just like it'd be helpful for folks to hear it. But what would you say on sort of the medical use of race, right? What would you say? Should there be a medical concept of race that takes race to be at least biologically important. Certainly someone who would engage something like epigenetics would take it to be biologically important, but not necessarily biological. And perhaps what would you say to someone like maybe Michael Hardiman, who thinks that, you know, there is something to the physician who asks you a barrage of medical related questions about your race, that there is something significant there. We can talk about that a little bit later. So if you would like to, or we can just go with Grant's question.
So I just want a little clarification on where trust is coming in for you in the organ donation scenario. I think I know where you're going, but I don't want to assume what you mean.
If people don't trust medicine, they're not going to donate organs. If people don't donate organs, a lot of people die. Right.
Okay.
So.
Yeah. I thought you were going somewhere slightly different. Well, still on the right. So I know that there's this line of thought that is often attributed to Black people that, oh, if you become an organ donor, the physician, you know, is not going to do everything they can to save your life. They're just going to kind of
my stepmother
carve you up, right?
Right. You are irrational for, and she has good reason, I think, for promoting the view, but yeah, she's like, you're gonna go in there for like a broken like leg or something like that. The doctor's gonna be like, you know, Black dude, free organs, right? You know, I don't know if I go that far as her justification, but yeah.
Yeah, no, I mean, I've heard that line of thinking. And in those instances, right? So I think as I was trying to kind of tease out in the talk a little bit, and again, these thoughts are still fairly preliminary. I do think that the onus is on institutions, on these kind of moments of structural injustice to show a kind of trustworthiness, right? This isn't about fixing Black people's paranoia. And to the extent that that becomes the angle at which one approaches the question, I don't think that it does a service to Black people. And I don't think that it does a service to whatever this larger goal may be. Because we know Black people aren't a larger goal in ourselves. There's always, let me not be inflammatory. I don't think it does, right? So if your goal is to kind of increase numbers of organ donors, I think that there are lots of ways to go about that don't rely on assuming that Black people are just paranoid and ridiculous. And so that's where, it's not that I'm skeptical about trust in general, or that I don't think that trust matters. It's that I think sometimes trust becomes a way of not address, right? A reliance on trust can become a way of not addressing other things that are incredibly important. And you know, just one quick thing about kidney donation, Black people disproportionately need kidneys for lots of reasons, including kidney failure as one of the many complications of diabetes. And, you know, we disproportionately have diabetes and disproportionately experience some of the worst complications of diabetes.
Yeah, I see. So it's not that you don't think trust is enough in terms of cultivation. You just think that the onus of cultivating the trust is on institutions and not to be placed on Black people.
Both. I mean, I don't think it's sufficient. Right. I think both things are true. It's not sufficient, but also to the extent that it works when it works, it's not, the onus should not be placed on Black people, right? There's this kind of implicit need to fix Black people. And I don't think we need fixing.
Right. I certainly agree.
So, I mean, just to give a quick answer to your question for me, I mean, and I said this at one point in the talk, I want us not to focus on whether race has a biological reality. I think this is, like, we've just been talking about this for a long time, and it just doesn't, to me, get at the heart of the problem. Instead, I want people to focus on what racism and experiences of being racialized do to the body, right? So, so when we have something like BIDIL, race is serving as a proxy for genetics, right? So there's this promise, this ideal of genetic medicine, personalized medicine, genetic medicine. You're gonna know exactly how, or with some level of great certainty that medicine is always striving for, how a particular drug is going to affect that person because you know their genomics, right? And so, but race is not a proxy for genetics. Like that's an old idea, just kind of coming back again and again, right? That, that Yolanda and I have, similar genetic makeups because we're both classified as Black in US society is not necessarily true, right? I mean, there's a lot of, we just don't know, especially in the US, right? Where there's, a history of a lot of race mixing and a lot of waves of, people coming and people's, for ancestors coming at different times. I mean, there's just so much about the history of the movement of people and reproduction that goes into how genetically close or far away people are from each other, that I just don't think you can sort of be in the US and say, oh yeah, this Black person and this Black person probably has something in common. This, second generation, child of African immigrants, and this person whose parents were brought over in slavery, during slavery and mixed a lot, through, the rape of their foremothers, right? Like with white people, this is not like, this is just two really different genetic paths, right? So I think we can't just sort of say, oh, these people share a race, therefore they're going to react the same to a particular medicine. But I do think we should pay attention to the ways that being racialized in the US, racial segregation in the US, deforms, experiences of discrimination and chronic stress in the US for people of color, the way those things might do similar things to bodies that are living in this country. So it's just I want us to pay attention to the effects of racism on the body, but I don't want us to recreate the idea of a sort of biological genetic form of race, particularly for the capitalist purposes of, relicensing medication, to make money.
Yeah, thanks. Thanks for taking all my questions too. I've been conference starved, so this interaction with people is fantastic. And what's up to Kamisha and Yolanda? Picking up, I think, on where you were going there, Kamisha, and trying to connect it to the idea of trust, I find this discussion fascinating because the question of trust is in many ways connected, or it extends outside of, say, the Black distrust of medical practice, because, and I'm thinking what you were just saying 2 comments ago, Kamisha, it's not just that the scarcity of resources today pit the well-being of whites and Blacks against one another, but it's also that the distrust that many whites have of government and government efforts to help rectify racial injustice in many ways exacerbates the issue, right? Because I'm thinking of Metzel's Dying of Whiteness book, right? Where like any attempt to help rectify racial injustice when it comes to say medicine, there are a lot of poor white people that even though that would help them, they're against it because they think this is in some sense going to help that group, which is typically just being given handout after handout, right? And so it's not just distrust from the Black community, but there is this larger sense of distrust in general that I think is at stake here. And so, it's more of just a comment I want to throw out there for either one of you, because I think I'm trying to bring together both the points in a way that I have found fascinating. And anyways, thanks so much.
I can't recommend enough the book Dying of Whiteness. I think it's really interesting. And it really points to the way that racism serves as a barrier to actually improving health nationwide and improving healthcare systems and health delivery and all that stuff, right? That that some people are worried that that if health were covered in a more sort of socialist way, which would be the last word to use if you're talking to any of these people, but if health were covered, more broadly for more people in the US, they feel like somehow that's their tax dollars going to people outside their community who are not deserving, even as, in fact, many of those tax dollars do go to these communities and sort of their communities are very much in need of those kinds of support. But yes, I mean, I think it's a really important that book represents a really important element of what we think about in terms of race and medicine. So, my recommendation to everybody of that book. Go ahead, Yolanda.
Yeah, so one quick thing, I was thinking back to, what you were asking me about the poor whites and shrinking white lifespans, that, not just the book, but Grant's question reflects a kind of investment in a white racial project, right? That, you're gonna, what did Chris Rock say? I'm gonna ride this white thing out and see where it takes me, right? That becomes even more important than, the possibility of everyone getting better or everyone having improved health, and the kind of willingness and investment to literally die rather than contemplate the possibility that someone you perceive as undeserving of getting something is really fascinating. And the New York Times really kind of leaned into this in ways that I found annoying at the beginning of the Trump administration, where you find all these interviews with white people staring forlornly out the window at the possibility of losing, Medicaid. I thought Trump was just going to take from the Black people, and now my Meals on Wheels is getting cut too, and that's very disappointing to me.
So thank you, Doctors Russell and Wilson, for great presentations.